Sitting, so they'll need to stand. I'm Rob Grenfell. I'm the National Director of Cardiovascular Health at the Heart Foundation, and it's a very exciting morning for us to be here at the inaugural Morris Oration, which is a celebration of 60 years of understanding physical activity's role in health. So it's not only recognising the groundbreaking work, but it's also recognising the impact that physical activity has on our community. Now, I'd like to acknowledge the number of MLAs that we have here from the ACT Legislative Assembly, as well as many of the CEOs, senior public servants, and many of people from public health and physical activity sectors that are here today. Since 1955, the Heart Foundation has been involved in promoting and advocating for physical activity. It's estimated that 16,000 premature deaths occur because of physical inactivity in this country. It's right up there with smoking as a leading cause of illness and death in this country again. And we've calculated that it's an estimated $1.5 billion cost to the economy because of that. For some reason, there's a dangerous tendency to see physical activity simply as part of the obesity problem. It's not. It's separate in its own right. And Adrian's talk will be compelling evidence towards why we should consider physical inactivity as a health risk in its own right. It is a major modifiable risk factor in its own right, ranked up there with blood pressure, smoking and overweight. And its contribution to the total burden of chronic disease, not just heart disease, but right through the spectrum, number of cancers and certainly kidney disease, stroke and other conditions. The trouble for Australia is we're all getting less active. We should be moving more. Australia's health report says that 60% of Australians aged 15 and over do not do enough physical activity to benefit their health. And that figure seems to be getting worse. We await the Australian Health Survey data, which will be released quite soon, which we will unfortunately be seeing a worsening trend. We know that one of the best ways of building physical activity into our day is just by putting that incidental work in. The walking, promoting cycling, promoting active travel. And we need to reconsider the passion that we used to have for the physical activity we did. In the space of 2 generations, we've lost the capacity to use our legs, and it's getting worse. And we need to work out how can we in fact actually make that the easiest option to do. So we know it can save your life and reduce a heart attack. Now, Adrian will be unpacking the evidence for us today. So we're very honoured to have Adrian here today, as he is a leading expert, international expert on disease prevention. In a very brief CV, he did say he's just back from the Philippines where they read out his 2-page CV, and I won't be doing that today because I'd rather hear Adrian than Adrian's CV. He's had a very exciting day yesterday with the launch of the World Health Organisation Collaborative Centre on Physical Activity at Sydney University, and I think that's a testament to the dedication that he's had in the physical activity space, and I think we should all actually applaud Adrian's work in that, and I'd like to join me in some applaud for getting that up yesterday. And as we know, he and along with another 20 researchers at University of Sydney Prevention Research Collaboration, his research interests have a long area of physical activity, health, physical activity epidemiology, interventions to promote healthy lifestyles, and particularly the recent work in physical activity advocacy and policy research and translating that into public health evidence base. So I'd like to welcome Adrian to present this formative Morris Oration. Thanks.
Thank you and good morning, and it's a great honour and a pleasure to be doing this, particularly for the Heart Foundation, who have been instrumental as an NGO in driving the physical activity agenda when everyone else seems to lose it intermittently. It's also a privilege to give the Jerry Morris Oration. I've met Jerry Morris a couple of times, and even at the age of 85 or 90, his incisive recollection of exactly what conversations we had the time before, and pointed comments to me of my failure to deliver on things that I'd promised to do. And he was 90, and at the time I was probably 45 or 50, indicates his 40-year cognitive profile was probably supported by prolonged, vigorous activity throughout a lifespan. what I'm going to talk about today is I'm going to talk about how we understand physical activity and the history of it from a Jerry Morris perspective. I'm going to talk about some recent physical activity data from the now current National Health Survey 2011 to 12, talk about our history of promoting physical activity in Australia and its relevance outside the health sector. I'm going to be very controversial and surprise many of you in talking about mythologizing information when I talk very briefly about sitting and health in a way that none of you have ever heard before. And then I'm going to give us 12 precepts for action. Okay. When I have a yellow slide, it's going to actually indicate this is a policy issue that needs attention. This is something that we need to be doing, so it's a stop and think slide. And between my segments, I'll have green slides with bicycles on them. 60 years ago, cardiovascular disease was the leading cause of death in Australia. There was no real evidence on cholesterol and only early studies on blood pressure and very early studies on smoking and health. There was no scientific evidence that exercise, which is what we called it then, was good for you. The principles 60 years ago have moved forward dramatically, but the single event that catalyzed us moving forward was Jerry Morris, who almost 60 years ago, in 1953, published his paper in The Lancet, Coronary Heart Disease and Physical Activity of Work. And there's Jerry Morris in his younger days, and there's Jerry Morris at about the age of 87 or 88, when I met him, and he's got a slightly irritated expression on his face because he'd just broken his hip skiing. He did a seminal study of bus drivers and bus conductors. He said bus conductors are climbing up to 750 steps up and down per day, and bus drivers are doing no exercise, as he described it. And the rates of heart disease were higher amongst bus drivers than amongst bus conductors, by about 50% higher. And he was really attributing this to the lack of exercise amongst the bus drivers. He similarly did a subsequent study on matched civil servants and postal workers and found exactly the same kind of risk differential. And this was the very first study that had said that exercise actually has a demonstrable benefit across groups who are active versus those that are inactive in everyday life. So this was an important finding. And to summarize, he really showed that in the Jerry Morris study, coronary occlusion, which we now call myocardial infarctions, were much lower in conductors than bus drivers, as were deaths within 72 hours of your cardiovascular event. Very similar data within the next 5 years came from the other great physical activity first epidemiologist, the American Ralph Paffenbarger, that showed the same thing for California longshoremen, the sedentary ones compared to the active ones, and they lifted bales of things on and off ships in those days rather than just using machines to move them. But physical activity goes back well before Jerry Morris. Hippocrates described diet and exercise in moderation. No evidence, just thought it was a good idea to be balanced. Bernardino Ramazzini, a 17th century Italian physician, described tailors and people who sat at higher risk of death. Dryden, the British poet, described, "I have two doctors, my left leg and my right leg." Physical activity became part of a political movement in Northern Europe in the 1950s, starting with the youth gymnasia in Scandinavia and ending up with some of the Aryan supremacy thinking in Germany in the 1930s. I'm going to talk about the US Public Health Service in 1915 in a minute, and I'm going to later talk about Australian legislation in 1941. That is the most important piece of legislation ever passed in Australia, in my view. Unfortunately repealed in 1994. Okay, Somebody called F.C. Smith, never heard of them. They were an assistant surgeon general, a public health surgeon in 1915. He said, "The diseases of degeneration are increasing. This is true for both men and women. One reason for this is the lessened physical and increased mental work entailed by our complex social fabric. More people are engaged in sedentary occupations than formerly." 1915. They lack the normal assistance with which working muscles give to circulation. Becoming overloaded with food poisons, which brain work cannot burn up as physical exercise will, the arteries become brittle and weak, and the heart muscle flabby, like the biceps of its unfortunate possessor. The florid businessman succumbs to apoplexy, cardiac failure, perhaps. Another big, pasty-complexioned brain worker to nephritis. Another to fatty heart or to chronically overtaxed digestion, all of which could have been postponed for many years by a moderate amount of daily exercise. Almost 100 years ago, pre-epidemiological thinking. Interesting thoughts. The legacy of Jerry Morris is to stay on the case, to focus on physical activity specifically. He never looked at physical activity's relationship to other risk factors, but its relationship independent of other risk factors, and that's an important message. To accumulate evidence and to monitor progress systematically. When he wasn't being a physical activity and exercise researcher, Jerry Morris was an epidemiologist, taught epidemiology at the London School of Tropical Medicine for many years, and wrote a classical textbook in 1957, The Uses of Epidemiology, which was reprinted 3 times. His legacy was evidence and monitor progress. In that context, I'm going to talk briefly about the cardiovascular evidence for physical activity. And by physical activity, I do mean exercise, which is structured activity. I also mean sport, which is group or organized structured activity. But I mostly mean physical activity, which can be incidental and accumulated in everyday life. I also mean all domains of physical activity, how you get to and from places, what you do in your leisure time, what you do at home, how you travel, and what you do at work. And I don't mean that, which is a wonderful form of creating inactivity from the most active opportunity that you can do. And I've observed one of those in suburban Sydney, in the suburb that I used to live in Strathfield, with someone driving around the dog off leash, running around on the footpath around a park. Okay. Physical activity has major health benefits consistent with all the health targets and goals we've set over the last 20 years for cardiovascular disease and diabetes, for mental health, for cognitive function, for reducing the risk of dementia and Alzheimer's disease separately, for some cancer prevention, particularly colon cancer and breast cancer, for injury prevention, for bone health, for functional status, for anti-aging, for mental health benefits. There's a panoply of benefits that would take a whole symposium to deal with. But we summarized our status in our Lancet Physical Activity paper last year by using the Bruegel painting from 1560, which is actually shown in the Vienna Art Museum, and I saw it a couple of weeks ago. And it's called Children Playing, and it shows children playing in an open space. And the 21st century variant of it is they're actually all inside on their iPads and iPhones, and actually no longer doing what they once were doing. We also estimated in our Lancet population attributable risk studies that physical inactivity contributes to 9% of chronic disease, exactly the same as tobacco and more than obesity. If that is true, and we used a very conservative population attributable risk modeling estimate, a multivariate adjusting for other risk factors, one much more conservative than the burden of disease. If that's true, then our expenditures are relatively modest for physical activity compared to our expenditures on smoking and on obesity. Reviewing the evidence on heart disease, I'll do just for a couple of minutes, and many of you will know some of this. I had a period of time over many years where I'd get all the cardiovascular papers and I'd actually look at each study and look at the physical activity or fitness relationship to cardiovascular or all-cause mortality. And wherever you looked, the maximum decline occurred in moving from the least active or least fit to a little bit more active or in the middle. That's where the maximum decline tended to plateau. And I did this in periods of time, and every time I did this, you got the same kind of relationship. This was 3 years later. This was 3 years later. I stopped doing it after 2006 because I think the idea was clear. Cardiovascular disease in particular is prevented by inactive people doing something more and moving toward what we call a moderate or minimal physical activity recommendations of 150 minutes a week. And that's really a first important idea. They summarized it clearly in the US Surgeon General's summary antecedent to their guidelines report, where they looked specifically at cardiovascular disease and looked for coronary heart disease, for cardiovascular disease overall, and for stroke. There's a clear dose-response relationship between levels of physical activity and coronary heart disease outcomes for men and for women, for cardiovascular disease the same, and for stroke a fairly similar relationship with a dose-response relationship for women, although the moderate seems to be even lower for men. So that, in other words, for cardiovascular disease in particular, we know that physical activity has particular benefits. You're all very familiar with the fat and fit the changes in physical activity hypothesis. If you remain unfit or inactive, you're very different to those who adopt physical activity. And you can adopt physical activity at any age. Inactive people in their 30s, 50s, or 70s will confer a benefit by changing to becoming active or fit. Not ultra-fit, just moving from the lowest fifth of the population to the middle, which is moderate activity. And by remaining active, you have the lowest rate of all. Is it physical activity or fitness? It's either. Fitness is objectively measured, and the least fit differentiates itself with a higher mortality than the other groups. The least active third in this Copenhagen cohort does exactly the same thing. So however we measure it, even imprecisely with questions, we differentiate health risks on the basis of physical activity behavior, fitness, steps taken, however you're counting it. In addition, across levels of body mass index, there's a clear relationship. In other words, when we look at the risk of cardiovascular deaths without adjustment for BMI, when Steve Blair, in this case in the aerobics longitudinal study cohort in Dallas, in Texas, when you adjust for BMI, it doesn't make any difference. In other words, firstly, the risks are independent of BMI, and Steve would contend that the risks that physical inactivity poses to cardiovascular disease in particular are more important than BMI, certainly below BMIs of class 1 or class 2 obesity, BMIs of 35 to 40 and above do pose huge cardiovascular risks, but below that, physical inactivity is a much greater risk factor, which is 97% of all the cardiovascular events. I'll skip over that one. Next, walking alone is sufficient. There are many studies that show the dose-response relationship. This is a women's longitudinal study in the US, Joanne Manson's work. There's a dose-response relationship in cardiovascular risk for women. Large case control studies across 52 countries show this is an international phenomenon. In other words, it's not just something we see in Australia or the US or England. Across 52 countries, there's still a 28% risk reduction. 0.72 is the relative risk in the Inter-Heart study, indicating that across countries, physical inactivity is a risk factor, as is smoking, as is hypertension. That's no surprise, but there's limited evidence from developing and middle-income countries, and this is one large case control study that demonstrates that that's the case. This slide has a yellow background. This slide has policy implications which worried me at the time in 1990 and perplex me now. My good friend Ken Powell did a systematic epidemiological review of all the evidence of physical activity and cardiovascular disease in 1987, From Harvard School of Public Health, Jesse Berlin did a meta-analysis in 1990 showing a 1.9-fold increase in coronary heart disease risk in the inactive compared to the active. If we knew that in 1987 or 1990, why didn't we act on physical inactivity sooner? In other words, what was the delay? I'll talk later about how the Heart Foundation was in that space well and truly then, but the rest of the health system, the prevention sector, was not as engaged in that space until substantially later. Another issue is once we have evidence, we write guidelines. We're quite good at doing that. And we wrote guidelines for physical activity in 1999, which was one of the earliest countries to get our guidelines out about 30 minutes on most days of the week. It's now described as 150 minutes a week. A little bit of extra activity is good for you. And we also have guidelines in 2012, but they're in grey. And they're in grey for a particular reason. Wendy Brown, who's here from the University of Queensland, led a group with Fiona Bull and I writing the adult guidelines, and there were children's guidelines. And we submitted our guidelines report, and it was approved by the Commonwealth Department of Health in June 2012. I'd like to wish our guidelines a happy birthday. Unfortunately, the guidelines have not yet been released. And it indicates part of the problem with physical activity's relative positioning. Obesity guidelines, tobacco guidelines get out faster than this. That we produced guidelines for adults, and another team commission produced very thorough guidelines for children, and we know what those guidelines are, but they're coming soon. And that brings us to the kind of under-recognition part of physical activity that's one of the subtexts of my theme, which is that physical activity doesn't quite have its place at the table that the evidence would suggest, and that involves all of us in rethinking physical activity a bit more clearly. But if the guidelines were to be released to you today, they might show things like any activity is beneficial, in other words, moving from nothing to some activity is good. The maximum benefit might be in the 150 to 300 minutes a week. There's no upper limit. The benefit continues to increase at higher levels, but injury risks also increase. But that's what the guidelines might show if they were released to you today. They might also talk about sitting, but I'm going to talk about sitting in a different context a little bit later. Next is physical activity and clinical prevention. And this is an area that is a very difficult one to work in. Clinical settings are an obvious place for promoting physical activity for people at risk with pre-diabetes or risk factors for heart disease, or for people with cardiovascular disease, with some cancers, with diabetes. Physical activity should be and is evidence-based to be recommended. So the clinical setting is one that we tend to ignore. I'm going to talk about the clinical setting for a minute. Firstly, changing physical activity or increasing physical activity seems to have a physiological response, particularly in terms of cardiovascular disease, and that's probably through increasing stability of the cells lining the coronary arteries and possibly through additional collateral circulation. But the effect is acute. In other words, if you're physically active, the effect is relatively soon that you'll see a benefit in terms of protection. And that's certainly true for glucose metabolism and diabetes. It takes a lot longer if you're a smoker and give up smoking to reduce your risks of heart disease to that of a non-smoker, at least 5 years. Ditto, if you have obesity and you lose weight, your risks will still be maintained for a little while longer, maybe 2 years, than compared to physical activity. So the risks are acute. The Heart Foundation, even nearly a decade ago, produced physical activity guidelines for people with cardiovascular disease, not exercise guidelines that they'd produced 20 years before that, but physical activity guidelines. The benefits were listed, and the greatest benefit is activating those who are least active with cardiovascular disease. So medical practitioners should provide brief, appropriate advice to people with clinically stable cardiovascular disease and to most other patients too. Why is that such a hard thing to do? In New South Wales, we've done representative samples of general practitioners. We've done 4 serial surveys, starting with Tony Stubbs, who's now the CEO of the Heart Foundation in the ACT, helping us do the first couple in New South Wales, and we've done 2 more since then. And we haven't shifted general practitioners' self-reported practice on advising patients about physical activity with or without chronic disease in nearly 20 years. Now, it means they haven't even learnt the message well enough to get the social desirability bias of telling us that they're doing it even if they're not. And yet their rates of advising smoking in all patients who come in the door, they describe as over 90%, and that stayed stable. Rates of measuring weight have increased. Rates of recommending physical activity haven't changed. So this is a tough area. Now, I'm going to talk about a couple of studies. A German cardiologist called Hambrecht has done 2 interesting studies, one 20 years ago and one 10 years ago. But they're the most intriguing studies you could see. Firstly, does exercise have an influence on atherosclerosis? And he randomized 2 groups of patients to exercise and controls. He followed them up with a maximum fitness test and with angiography. He looked at regression of atheroma documented objectively, and he found that the energy expended, the most active showed regression, compared to the least active showed progression of their atherosclerosis. Then he did a study which is even more compelling, but would be difficult to get through an ethics committee. And for those of you who know a cardiologist, please tell them to look at Hambrecht's study from 2004. I'd like every cardiologist you know to have a look at this study. It's a fascinating study because what he said is if regular exercise improves heart function, then we should be able to compare a physical activity program to stenting, which is a cardiac procedure in people with stable angina. So we take people with stable angina, so they're unlikely to have an infarct, but they are likely in the medium term to. And we compare them to stenting versus an exercise program. And what he did was he took 101 male patients, older age, randomized them to 12 months of exercise or percutaneous stenting. And that's an interesting study. I'm not sure an ethics committee in Australia would get through that. I'm not sure the routine practice in cardiology of stenting uncomplicated angina would be happy with this study. You can see where it's going. Basically, he compared a 6-week exercise program with stenting, and what he found was quite interesting. Firstly, in terms of the outcomes that you might expect, the lumen diameter, the width of the coronary artery in the exercise training group didn't change, and in the stenting group did change. They made it wider. That's the objective of stenting, so that the stenting had achieved its objective in terms of widening the coronary artery so it wouldn't get blocked and have a heart attack, and the exercise training group didn't do that. But the physical work capacity, fitness levels measured by physical work capacity and VO2 max increased in the exercise group and didn't change in the stenting group. So the exercise group got fitter and the stenting group didn't. So they achieved their physiological outcomes that their allocation was supposed to do. But the event-free rate in terms of 12 months reinfarctions or recoronary rates was much lower in the exercise group than in the stenting group. In other words, the stenting group had more representations for cardiac events than the exercise group. This trial's never been repeated. It's not widely cited in the literature. About 7 years ago, the Heart Foundation invited me to go down to the Cardiac Society where I presented this, but unfortunately there was a seminar put on by the pharmaceutical industry in the lecture theatre next door. So Heart Foundation staff outnumbered cardiologists at the physical activity lecture. So we've got a long way to go. It's the Cinderella metaphor again. But if the case is strong for physical activity advice, this is a yellow slide, we need to increase it. Advice from all health professionals, from physiotherapists, why not from dietitians, why not from podiatrists, why not from all levels of medical practice. Brief advice is effective, the systematic reviews show so. Even simple 2-minute advice is substantially better than nothing. We need to support people in making changes. If we've got a therapy that is as effective as clinical therapies or even procedural interventional cardiology. Okay. Next, I'd like to talk about physical activity surveillance for a few minutes, just to see where we've come from in Australia and how we're doing. How's our physical activity tracking? And unfortunately, all these slides could be yellow because they've all got a policy implication. But I'm going to start with the very first slide. Will take you through to a 1987 paper, my very first paper on physical activity. I was actually an asthma epidemiologist in my earlier life when I moved to public health. Then we had the 1990 Fitness of Adult Australians. You won't find a copy of that anywhere, but I've got one on my shelf. It's very old. That was only done once. We have state-based CADI surveys. We've got the ABS National Health Surveys and the more recent one with objective data. We've got other non-health data systems like transport data systems, ERAS, the sport and rec surveillance systems, unfortunately stopped in 2010. So we've got a whole bunch of surveillance systems, but I'm going to show you what we do with surveillance in Australia. This slide is a photograph of my first physical activity paper, where I used different data sources, including the Heart Foundation risk factor prevalence studies, where they'd taken the word brisk out of the walking question and the prevalence dropped. Other data sets from then Sport and Rec, from a Roy Morgan survey and from the ABS produced completely different prevalence estimates. So it's the Alice's Restaurant approach. You can get any prevalence estimate you want at Alice's Restaurant. Just ask me and I'll give you the prevalence estimate you need. In other words, if you ask different questions or you measure it in different ways, you get different prevalence estimates. And the same thing applies to objective measures for those of you with an exercise science orientation. In the National Health and Nutrition NHANES survey in the US, in 2003, they had accelerometers on the hip, and in the 2010 National Health and Nutrition Survey in the US, they put them on the wrist because it was a better accelerometer device, it gave a more up-to-date measure, and it was a better technical device. Non-comparable. As non-comparable as we see with self-report measures. And that I describe as gadget obsessive disorder, which is the desire by exercise scientists to have the newest technology. It's like mobile phone technologies. The newest accelerometer, the newest pedometer, the newest measurement device isn't necessarily going to give us surveillance data. And I said in this paper in 1987, if we don't have a standardized surveillance system in Australia, we won't get anywhere. We haven't. 1,000 surveillance systems bloomed. And some, like the National Health Survey, were measuring exercise, but at least consistently measured exercise until the most recent one, so that we could see that the prevalence of no or low exercise was actually increasing over the 2000 to 2008 National Health Surveys. We can see sedentariness was increasing in men and women. But state data provides a different pattern. National exercise is decreasing. State data that's looking at an Active Australia, which is a broader, more inclusive measure, in New South Wales shows a slight increase over the last few years for men and a slightly smaller increase for women. Same thing for Western Australia, a slight increase in sufficient physical activity by about 4 or 5%, which is significant over the past decade. So which is right and which reflects adult Australians, and which surveillance system should you use? Whichever data system you like on the day. One isn't better than the other. They're both representative samples. They're measuring different things. And that's an important idea. The latest findings from the ABS National Health Survey suggest that, this is just released last Friday, that 43% of adult Australians are sufficiently physically active. That proportion declines with age. Males are slightly higher than females. And when you look at how they accumulate activity, it's quite interesting because walking for fitness increases with increasing age. Other things like vigorous activity decreases dramatically with age. Strength training is very low in all groups, and gardening increases dramatically in older age. And that's important. We need to measure those incidental forms of activity to get a total picture. I'm going to skip over some of that, and I'm going to skip over children's sedentary behaviour too. One of the interesting things in the ABS objectively measured health survey was they had pedometer data for kids and for adults. And I'm going to show you some of that with Katrine Tudor-Locke's conceptualization that kids need to achieve 11 or 12,000 steps and older adults somewhere between 7 and 10,000 steps a day. The proportion meeting 10,000 steps a day in the National Health Survey is around 18%. It's a much lower estimate than the prevalence estimate that we get from self-report. It shows an interesting age gradient, declines with age, but peaks in middle age, whereas the self-report data shows a dip, the obverse pattern. Interestingly, we accumulate about 7,000 steps per day. Again, lowest in the 75 plus, but increasing in middle ages, similar by gender. So it takes away the gender distribution, the gender maldistribution. How does this compare to other people's pedometer data? American data from just one self-report study in America on the Move suggests that Americans accumulate 5,000 to 6,000 steps a day. However, a Canadian National Health Survey, very similar to ours, indicates that Canadians are averaging about 9,000 steps a day, which is more than us. And a Norwegian study, about 8,500 steps a day for all Norwegian adults, men and women. So that Norwegians and Canadians are more active than us, objectively measured by 1,000 to 2,000 steps a day. That's significant. And that's an interesting comparison because it's using the same metric. Objective measures in kids meeting the 12,000 steps per day declines dramatically once you go beyond primary school. Primary school kids are active, secondary school kids lose it completely, boys and girls. This shows a more dramatic decline than we've seen for boys in early secondary school. Canadian kids average about 11,000 steps a day. Australian kids average 9,000 steps a day. Canadian kids in their CanPlay study average about 11,500 kids a day, objectively measured nationwide sample. So we're less active than Canadian kids. These are objective measures that matter. Okay. And they've got a surveillance system in Canada. Their step counts are actually measured each year in a population surveillance nationally that show things haven't changed. But having a surveillance system which is objective gives them information that we don't have. Data everywhere, and a limited policy response. We get new data, we get very excited about it, the transient agitation, and then we resume our resting state. So that when we get excited that most Aussies travel by car, yesterday's headline from the recent National Health Survey, did we sort of know this before? Yes, we did. I'm going to skip over that. We knew that before because we've plotted transport data using travel surveys that show that cycling and forms of walking have flatlined in Australia over the past decade. So we really know that. So the question is, when we've got data like that, we need to make advocacy use of it, not just get transiently agitated and then settle down again back to our resting state. Okay, so this really brings me to my next and second last piece, which is, well, firstly, physical activity prevalence is question dependent. Recent ABS survey is interesting, but we need a surveillance system in Australia, not just physical activity questions. A system that's maintained, that's consistent, and that asks the same questions. No matter how imperfect the questions are, we should stick to them. Okay, we need to know things like when the line is flat, we need to do something about it. or when the line's going down for kids in New South Wales in active travel, we need a policy response. Okay. Where have we been in physical activity in Australia over the last 20, 25 years? Firstly, in 1941, we did a great thing. We had the National Fitness Act. The Governor-General appoints a council for fitness and advises the minister with respect to the promotion of national fitness. Measures to develop appreciation of the need for fitness, we call that social marketing. The provision of facilities for instruction in physical education in schools, training of teachers and leaders of all groups, the organisation of movements and facilities for attaining personal fitness. The Council may make inquiries into the causes of fitness and report to the National Health and Medical Research Council. There's an account, there's a budget for it. The monies will be applied to encourage fitness in each state under the direction of a national council, to encourage schools, universities and education institutions and other purposes as specified. And the minister each year shall cause a general report containing a summary of the work done under this Act to be prepared before Parliament. What a wonderful Act. And it had Keep Fit books, and it was reported on in the MJA, although I've gone back to the original Act to present you that. Where have we been in physical activity in my period in the last 30 years? We had the exercise period, which was the pre-1985 or 1990 period where we focused on heart rate and cardiorespiratory fitness before the Surgeon General's report in 1996 started to talk about moderate activity, but the Heart Foundation of Australia was talking about moderate activity 5 or 6 years before that. The Heart Foundation started with exercise and health in the 1980s, but moved to the very first mass media campaigns in Australia in 1990 and 91. We evaluated them. They used role models like Greg Norman, who was then an Australian, exercise, make it part of your day, exercise, take another step. They used soap opera like A Country Practice and the stars of that as credible role models and ran a national mass media campaign, 2 of them. And we evaluated them carefully, and the first one in particular showed quite dramatic increases in understanding that physical activity could be good for them, and the models that they used in the media messages were walking and moderate intensity activity, and half an hour a day, even before the Surgeon General's report. Then the Heart Foundation also developed a National Physical Activity Committee in the 1990s. I was fortunate to chair it for its first 10 years. And it had academics and Heart Foundation staff and was really a way of the Heart Foundation organising itself around developing physical activity nationally and being there consistently when governments at all levels were in and out of the physical activity space. The campaigns we've run for a long time, no one actually evaluated Norm. He may have done more harm than good. The Heart Foundation campaigns we described here. Active Australia was a series of campaigns that Bill Bellew in the audience in New South Wales spearheaded as part of a partnership between Sport and Rec and Health federally. And we've had other campaigns since then. Wendy Brown in the audience did the 10,000 Steps Rocky campaign in Victoria, and Trevor Shilton did about 7 years of Find 30 in Western Australia, also from the Heart Foundation, and here in the audience today. Then we had the sport and recreation era, and that was really about trying to link to community sports participation. In the mid-1980s, there was a strong community focus, and I had a lot of dealings with the then Department of Arts, Sport, Environment and Territories. That faded. Then was the Active Australia Partnership. That lasted a little while. Then that goes in cycles. And this cyclical interest in physical activity at the community level for sport, or interest in physical activity and health even amongst DOHA staff, hasn't yet stimulated our shared interagency agenda, and we need to do that. At the state level, we've had some very good progress in task forces that had the imprimatur to do things, but they've all been fixed term. I chaired the first one, which was the New South Wales Premier's Task Force. It lasted 8 years, and now it's turned into something called PCAL that has nutrition in it as well, and it's losing some of its physical activity focus. An excellent task force in Western Australia lasted for 10 years and was only disbanded last year, but actually worked across government out of premiers, so it had the right imprimatur and was an interagency group that did a whole range of things. It's reformed itself as the Active Living Committee, and that's an excellent West Australian initiative. For communication systems around physical activity, we've done things through the intergovernmental committees at the time of the Active Australia Partnership, through AusParNet, another Heart Foundation communication strategy that communicates by an e-newsletter to 3,000 people each week. If you aren't a member, sign up if you're interested in physical activity. We just send out research conferences, what's happening, what are the policy directions. The strategic NGO prevention alliances, and our global supporters of physical activity, including the World Heart Federation and others. And the Heart Foundation National Physical Activity Committee continues unabated, chaired by Professor Joe Salmon from Melbourne. But I want to bring us back to the healthiest country by 2020, our national preventive health strategy. Preventative, but it's now preventive health strategy. The targets, you know, about obesity, smoking, drinking, and closing the gap, admirable public health targets, but the infrastructure strategies also related to physical activity. And one of the promises made in that was to establish a Prime Minister's Council for Active Living and develop a COAG partnership on active living. Now, those are politically difficult to achieve from where we are today, very difficult to achieve, but if we're taking physical activity seriously, the younger of you in the audience, the next generation of physical activity advocates have to see those things happen. Have to see those things happen in your working time, or your work is not done until they do. So that's an important idea. Okay. All right. Have I got 5 minutes more? Okay, well, I'll be very quick. I'm going to talk about sitting, which is something I often talk about because I do a lot of research into sitting and health. And we have placed sitting as the great new risk factor. And it's very evocative and it's very marketable as an idea. And I'm going to just place it in the opposing agenda to look at whether the evidence is really consistent. Are researchers being too positive with results, and are there potential unintended consequences? I'll talk about that in a minute. Peter Medawar said, a Nobel laureate, "I cannot give any scientist of any age better advice than this. The intensity of the conviction that a hypothesis is true has no bearing on whether it's true or not." By sitting, we mean not light activity, which is what I'm doing now, and standing, we mean sedentary behaviour, that less than 1.5 METs, and these are the health-enhancing activities that we use for physical activity. So I can be inactive, which I am now, but I'm still not sitting. So we try to differentiate the health consequences of sitting behaviours, and there's all kinds of studies showing sitting's related to all-cause mortality. It is related to glucose and insulin metabolism, I agree with that. Is it associated with obesity? If we sit all day, will we gain more weight? What's the evidence on that? Sitting and cardiovascular disease risk, what do the studies show? And is it independent of physical activity? Sitting's increasing across the world. We're sitting more. That's incontrovertible across occupations and across developing and developed countries. We spend more time sitting in professionals and managers. Again, the most recent data. I'm not going to go through that. And we find that sitting in some studies is associated with all-cause mortality, even using poor questions from a Canadian study, associated with cardiovascular mortality, but not with cancer mortality. And when you stratify by physical inactivity, it's stronger than for activity. In our New South Wales data, sitting 8 to 11 hours is risky, and more than 11 hours a day increases your risk of all-cause mortality in the 45 and up study in New South Wales, and appears to be somewhat independent of physical activity. You're in the best category if you're high active and low sitting, the highest risk if you're high sitting and low active, but these people are high active and high sitting, and they're not that different to these people who are completely inactive but don't sit. They just move around a bit all day. So there's some evidence in this direction. But I want to introduce you to an epidemiological concept called negative findings and delays in publication. And one example of this is sitting and weight gain. There are 1 or 2 studies that show a relationship between prolonged sitting and weight gain over time. There are 1 or 2 studies that fail to show this relationship. There are 4 studies that I know of across the world, I'm only involved in one of them, that have looked at this relationship and failed to show that relationship. But because they're negative studies, they're finding a hard time getting published. So US policymakers don't know about them. So by the time the evidence gets out there, we'll be several years down the track of the idea of promoting sitting as a really important public health response. So firstly, the evidence is suggesting that it's not sitting causing weight gain, but reverse causality. Obese people increase the sitting time that they do. And that's a very important epidemiological distinction. And we need to be very careful before we jump into policy pools not to overmarket our message. Even for diabetes incidence and CVD, the sitting health outcomes relationship is not yet consistent. It's there for all-cause mortality, but eating chocolate is there for all-cause mortality too. It's protective, and I can show you several studies of that. So that all-cause mortality is a crude metric of disease-specific and real risk in epidemiological studies, but is highly publishable if you find interesting findings. So we can start to mention sitting, but it might be premature to change our entire working space across the entire country. And I'm not even sure if we should be recommending reduced, we certainly should be for kids, we certainly should be for kids less than 2 hours a day, but adults, screen time, yes, but work time, it's a difficult area. And I'm just going to pose one unintended consequence. If we focus all our energies on sitting, where will we take resources from to do that? From physical activity funding, because we'll see it as the other side of that coin. And if the risk for physical activity is 1.9 and the risk for sitting is 1.1 in reality, we're diverting resources from a larger health risk to a smaller one, and that's an unintended consequence. So I'm cautioning sitting thinking more than I have done ever before. Jeremy Morris would say we need sufficient data, we need multiple settings, and we need to exclude short-term follow-up or confounders in the sitting studies, and they haven't been done. So the public health case, we're normally in public health, we're ahead of the data. With passive smoking, we were ahead of the data and we were right. I'm not sure we're going to be as right for sitting. We need to explore this, and we haven't fixed the old problems of physical inactivity yet. So, physical activity is Cinderella. It's the Cinderella risk factor. If we think about it as Cinderella, it's poverty of policy attention and resourcing relative to its position. How are we doing in the Cinderella precepts? The strength of evidence is fully accepted. We're doing well. This is on a 5-star rating, my personal 5-star rating. So this is completely qualitative. We're doing well in getting the message across. Consensus-based guidelines, we need to release our guidelines and then disseminate them. The Canadian guidelines have been released twice and not disseminated. It's identified as a discrete risk factor. We need to unembed it from obesity and deal with its effect on functional status, aging, mental health, and other things. Low and middle income countries, that doesn't apply to us so much in Australia, but it is an issue for Indigenous populations and for culturally and linguistically diverse populations who are less active. Population levels can be changed. We still don't believe that in policy land, and we lack ownership of the problem. We haven't got integrated action. We score a 0 because we keep on disbanding our task forces. Advocacy, we're getting better. You need to get better still. We know what to do. The 7 global investments will tell us what to do in schools, in transport, in urban design, in primary care, in mass media and community-wide programs, and in sport. And so to conclude, my Jerry Morris conclusions. We need to use evidence carefully, not as an overnight sensation, and take the evidence on physical activity and work with it a lot harder. If it seems as important as tobacco, why doesn't it get equal attention? That's an advocacy case until it does. If there are guidelines, A little physical activity goes a long way. We have got achievable behavioural targets for Australians. If we knew about it in 1990, why did it take over a decade? And if clinical settings are such a useful place, is that really too hard? It may be. Or is that the next big challenge for us? We do need a standardised surveillance system. We are objectively less active than Canadians or Norwegians. It's the first time that's ever been said, but I think the evidence is good for that. When do we need new data, or do we need new advocacy? In other words, how much data do we need to transiently agitate ourselves and then return to resting state? We need the continuous agitation. We need to learn from history and dream of the return of the National Fitness Act that was repealed, unfortunately, in 1994. Our physical activity work is characterised by cycles of interest and relatively less interest and less interest, and our sustained tobacco interest pales that into insignificance. And can we hope for a National Council for Active Living? And we need to be careful not to mythologise data to see the new big thing, and rather try to think through how can we solve the problems we've already got better, because they may be contributing greater risk. In honour of Jeremy Morris, thank you for your attention.
Thank you so much, Adrian. We have time for just a couple of questions if anybody has any burning questions. Certainly.
Yeah, Crispin. Adrian, what's your evidence that the National Fitness Act is an effective tool for improving or reducing cardiovascular disease in Australia?
There's absolutely no evidence, because it firstly was introduced in World War II, and I'm putting it up as an example of a policy directive and a policy direction. Now, nobody measured its implementation. Nobody measured cardiovascular risk. We just know that rates of cardiovascular deaths were extraordinarily high at that time in Australia. So we have no relationship between it and physical activity levels at the population level. But the act of encoding in legislation the need for government to do something about physical activity, which we've done for tobacco, which we're starting to do around food labelling and food marketing for nutrition, we may ideally not need to do at the government level if we're going to get intersectoral things that stick rather than go through the cycles. So it's not the evidence, it's the principle that it's an idea to aspire to, because we have evidence from tobacco and nutrition that policy and legislation as environmental changes do work. It was repealed in 1994 by the then Department of Arts, Sport and Territory. It had kind of lapsed for several decades, and it wasn't actually implemented as anything other than a dusty piece of legislation. So once you have policy, implementing it and observing that is necessary, and I don't know how many decades it had lapsed for, but I hadn't heard of it until 2011, and I've been in the physical activity space in Australia for 30 years, so it must have been very dusty.
Back one first.
Mark Level from the Consumers Health Forum. Why should it be that there is this lethargy over a stronger national activity approach? We look at smoking, which was imposed by, at the time, a very strong, well-funded industry and all sorts of other difficulties. Everybody agrees with physical activity. Is it because there's no strong opposition to it?
One, the opposition to it is too strong. We actually dare not mention it's he who shall not be named, because the creators of sedentariness are car manufacturers, petrol manufacturers, the entertainment industry, television sets, computers at work, all kinds of things, and that's even bigger than the tobacco industry was. Tobacco industry was a clear enemy. It was clearly doing evil. It was an easy enemy to develop a public health argument, especially when kids were involved. The tobacco smoke's influencing my kids, and people don't take physical activity seriously. Oh, walking the dog isn't going to do me any good. Why should I bother? Why should I use the stairs? We haven't created the cultural norms that create stair use. If you put Dutch people pre-intervention in front of stairs versus elevators, they'll use the stairs 10 times more often than Australians will as a cultural norm. So their pre-intervention rates are much bigger than we can ever produce. So we need to think differently about activity. And so we need to change the social norms of how we move ourselves through the day. And that involves culture change. And we did it with tobacco, but it took 25 years. And we're starting to do it with food. And I would contend that physical activity is a big challenge, but should be next on the agenda.
Gordon?
Gordon Gregory from the Rural Health Alliance. I just wanted to say, for me, that was a fantastic reflection on the relationship between data, evidence, policy and advocacy. And can I express the hope that it will be published?
Thank you.
Yeah, great. Look, I'd like to introduce Trevor Shilton, who is my colleague at the Heart Foundation, who's the State Director in WA for physical activity. And Trevor is the Heart Foundation's lead nationally on physical activity as well, leading NPAC. And he's also the Global Vice President for Advocacy of the International Union of Health Promotion and Education. That's a mouthful, Trevor. And the Deputy Chair of the Global Advocacy for Physical Activity. So I'd like to ask Trevor to have a response to Adrian. Thanks.
Thank you, Rob, and I will be brief. It's in the morning. You've all got places to go. But Adrian, that was a terrific oration and as eloquent a description of 20 or 30 or more years, in the case of Jerry Morris, 50 years of history than you will ever hear. And we are indeed very privileged to have somebody of Adrian's talent and intellect and at our disposal in this country. One sign of a field moving beyond its Cinderella status is its preparedness and its ability to recognise its champions. And Jerry Morris, of course, is celebrated today as being that champion pioneer, not just in physical activity and health, but so many other things that have come through that, including the connection with our workplaces and our work life in relation to the bus conductors and the British public servants. And his key messages certainly have stood the test of time. I heard Adrian talking about Jerry's key messages, and then I heard Adrian later in his presentation channeling Jerry Morris, talking about physical activity and its importance in its own right, talking about the importance of gathering evidence, the importance of monitoring, but most importantly, the importance of staying on the case. And I think if I draw another parallel to tobacco, the evidence was in 20 years before we saw a quit campaign, 25 years before we saw smoke-free policy and other legislative change. We don't want to see that kind of gap with physical activity. The number one priority we have to have in this field is advocacy, to get the, if you like, the policy responses matching the evidence that we have. So Australia too has its champion and hero, and one day we may in another generation be in this place listening to an Adrian Bowman oration. Adrian, that's why we invited you to give this inaugural Jerry Morris oration. We're very privileged to have you in Australia, an inspiring national leader in the field, a global leader in physical activity. I've done a lot of work globally. Every time I'm looking for a keynote speaker from Europe or America, they always tell me, you don't need us, you've got Adrian. He is without peer in the world, in my view. And Adrian was acknowledged a couple of years ago by the Heart Foundation, given the President's Award for his contribution to physical activity in this country in particular, but also globally. And finally, on a personal note, Adrian is an inspiring mentor, and his energy, his wisdom, probably more importantly, his generosity is second to none in this country and ever endless. In relation to Cinderella, we are seeing some progress, particularly globally. Rob mentioned a couple of global hats that I wear. It's fantastic to see the United Nations and the World Health Organization talking about 4 risk factors, physical inactivity being one of them, see that reflected in their targets and indicators that the world has now subscribed to through this 66th World Health Assembly, a 10% reduction in physical activity, inactivity rather, and also see it very well weaved throughout the Global Action Plan on NCD. So we are seeing some progress beyond Cinderella. I'd like to ask you all, I guess, in closing, to join with me again in thanking Adrian for a wonderful oration, and yes, it would be fantastic to see this published in some form. in part of that history, and some people in the audience were acknowledged, but I'd also like to acknowledge the critical importance of our National Physical Activity Advisory Committee. Adrian was its inaugural chair. Wendy Brown, who's in the room, Professor Wendy Brown from Queensland, is a former chair. Professor Bill Bellew is a former member, and the Heart Foundation does benefit enormously from the generosity of our professors and honoraries, as we call them, around the country. I'd also, just in closing, on behalf of everybody else here, acknowledge Rowan Greenland for his vision and commitment to this event and enthusiasm for the area of physical activity, and Megan Jeremenko, who's still very busy. For those of you who don't know Megan, this is her last day at work. She's about to go on maternity leave, and a very important next chapter in her life, but a tremendous amount of work on Megan's part in putting this morning together, so well done. And thank you all for coming, and I guess if you're to take one message from today, it would be to join us in the advocacy battle, to have the commitment to physical activity match the evidence that is there for it. Thank you very much, and thank you, Adrian. I have a gift for you.
Thank you, Trevor.
There you go. Well done. Thank you.